listening to the Pharmacy Podcast Network.
3, 2, 1.
Adverse drug reactions, or ADRs, are a serious issue in healthcare today. The pharmacist is the last line of defense to help prevent ADRs. A rising role of the pharmacist is the specialist who focuses on our children. Pediatric pharmacy ensures safe and effective drug use and optimal medication therapy outcomes in children up to 18 years of age. Currently, there are more than 1,450 board-certified pediatric pharmacy specialists, known as BPS. If you're interested in this expanding field of pharmacy, this podcast is for you. All right, everyone, let's give it up for our host.
Hi, everybody. This is Jenna Quinn. You're joining us here on the Pharmacy Podcast Network, and we are recording today Pediatrics in Review. I am here with my wonderful co-host, Justin. Justin, say hi.
Hey, everybody. Glad to be joining you again, Jenna.
And we are super excited to have on the guru of ADHD and really to learn from her. We have Miss Lea Eiland on. Lea, can you get us kicked off and introduce yourself? And again, this is one of my personal favorite topics, and I know Justin's too. So we're really excited to be here today and to learn from you.
Well, thank you, Jenna and Justin. It's wonderful to be here. I appreciate being asked to come onto the podcast today and speak about ADHD, such an important topic in our pediatric pharmacy world. So as you said, I'm Lea Eiland. I'm a clinical professor and associate department head of pharmacy practice at Auburn University, the Harrison College of Pharmacy in Auburn, Alabama. Practice in pediatrics more than 20 years, 25 years or so, and practice in inpatient and outpatient. And while I was an outpatient in general peds, ADHD was one of my favorite type of patient per se to see and to visit with, but really to talk with the caregivers and help them learn about the disease and taking care of their patient.
All right. Thank you for the introduction. Lea, after writing the review article guidelines, which summarize the AAP guidelines for ADHD, can you tell us what would be the key takeaways you would want our listeners to leave with today to get us kicked off?
Sure. So I feel it's important when we look at the disease state of ADHD. The reason Dr. Gilden and I wrote this review article is there's so many new drugs on the market today for ADHD, and they are all different. None are alike. And so we really wanted our providers to be able to understand that difference of these drugs, as well as make sure that everybody had an understanding of the disease and our diagnosis for ADHD. You know, it's very important to really use our rating scales, the DSM-5, TR criteria to diagnose a patient with ADHD. It's not just that a parent or a caregiver comes in and says, my child's hyper, or my child won't sit, or my child, doesn't pay attention. Oh, you have ADHD. No, we have true evidence-based guidelines on the diagnosis, the treatment, and the monitoring for this disease state. And with ADHD being one of the most common neurobehavioral disorders in children, we continue to see this disease, and we continue to see the drugs come about. We're going to have a lot more drugs continuing to come about, as well as we have a huge shortage right now. And I should say huge, but there are shortages, and depending where you are and what drug you're on, you may get it or not. So it's just important for people to understand the disease and then all the different treatment options that are out there, and that one drug is not alike to another. Being a pharmacist, I really think this is where, if you get into that pharmacokinetic, pharmacodynamic aspect of drugs, there really is a difference in our stimulant medications. And it's not just from a dosage form of like, oh, you can open a capsule or sprinkle some beads on applesauce. This is learning each drug's unique design, the amount of drug it's releasing, how it's releasing it, and then the amount of drug concentration in the body, thus leading to efficacy in the patient, but also potentially to adverse reactions. And so we also have to look at all of that. So from that reason, that is why we wrote this article, to provide another up-to-date, concise review of ADHD.
Lea, we'll dive into some of the depths of the pharmacokinetic interactions and just different factors later on here. But before we do, I'd love for you to maybe remind us today, how prevalent is ADHD? What percentage of kids do we see? I mean, Jenna and I are both parents, and I know we both ask questions about our own kids. Oh man, is my kid affected by ADHD? I feel like you're not a parent until you've asked that question at least once about your own kids. But I'd love to contextualize that for us. So in summary, how common is ADHD really?
Sure. The last data reports that we have show that approximately about 7.2% prevalence of ADHD, that's worldwide in our pediatric population. And then when you look at you can look at subgroups and ages, and your adolescents at this point have the higher treatment that they have ever had ADHD. But again, we've also seen through studies, like even the state that you live in the United States can vary in prevalence. We know males are more likely than females. And then we know Black non-Hispanics have a higher prevalence than white non-Hispanics. And our lower prevalence of ADHD is seen in our Asian non-Hispanic and then Hispanic populations. So a variety of patients, a variety of characteristics, but yet overall still 7% prevalence worldwide of this disease.
And I think that leads into our next question. And I think it's interesting because I swear at 35, when you look at the DSM-5, I would 100% be diagnosed with ADHD. But I also have anxiety and OCD. And so that leads to my next question. Like, in some ways, they all blend together. It's hard to differentiate. What are the common comorbidities you see with ADHD? And then later in the podcast, I love to know, how do you treat them? Because sometimes it's like, you have all these things, and how do you make the decision, okay, let's treat this child's anxiety versus their ADHD? So I just asked you like 20 questions in one, so I'll take a breath.
No, but those are all great questions, Jenna. So it is thought that patients who have ADHD, frequently they have other comorbid disorders. And so what we have found is oppositional defiant disorder in our young children, kind of more than the adolescents, adults. Half of them could have that. Well, half of them, but like maybe a quarter. There are different studies that show different ranges, of course. But oppositional defiant disorder is one. Conduct disorder is another one. Autism spectrum, OCD, as you were commenting about, as well as even tic disorder. So many of those can occur concurrently, as well as I'm going to say a lot of our patients with ADHD may have seizures. So you'll find some studies that were in patients with ADHD and epilepsy, and then they're trying drugs that maybe can help out both. So what the American Academy of Pediatrics recommends, and there are several guidelines out there, but what they recommend is to always screen for comorbid disorders, and then make sure you're treating those, because sometimes if you treat those, the ADHD will improve through that treatment of that secondary or primary disease state from that perspective. So it is not that all patients with ADHD may need a stimulant and non-pharmacotherapy immediately. We may want to treat the comorbid disorder first with whatever drugs that may require and behavioral therapy, and then see if the ADHD symptoms improve. I will say this is where the Society of Developmental and Behavioral Pediatrics, they created a guideline, and that was the most recent kind of update guideline. You would say they created a guideline in 2020, but they wrote it as essentially it's a work to complement the American Academy of Pediatric guidelines. Here, though, they talk about complex ADHD, and they talk about ADHD with other diseases. And there is where I think they have a great resource of helping you see what maybe is more prevalent of the patient for that individual patient and how can we treat that patient. So kind of using those two guidelines together, I think are very good in patients who have the comorbid conditions. When we're getting into other type of psych issues or psych diseases from that perspective.
Lea, you bring up a bunch of great points there. I think one of them is that ADHD not only has comorbidities, but often the symptoms can actually look very much like symptoms of other things. For example, generalized anxiety disorder in young children can really end up looking much like ADHD, with inattention and a child just seeming to not be able to sit still and forgetting things and struggling in the classroom at times. Sometimes that can just be anxiety, right? And so it takes a lot of skill to really tease out exactly what the primary concern is for an individual child. But I think that's where we have to go with our treatment. We first need to work with the families to say, what is the most concerning symptom or condition? And let's go after that first, because like you said, if we target the anxiety, sometimes those ADHD symptoms, if it truly is comorbid, will get better as well. So it's crazy how these all interact and kind of intertwine when it comes to treatments. And it's something I have the privilege of navigating with my kiddos on Wednesday mornings at a clinic here once a week. So I want to go to the AAP guidelines just really quickly and maybe have you summarize what are the first line treatments? How should we approach it? Probably more from a pharmacologic standpoint.
Sure. So the American Academy of Pediatrics, Justin, divides the treatment options into 3 different age groups. So we have to first look at the patient's age, and then we can see what is actually recommended from AAP. So they take that preschool group first, so the 4 and 5-year-olds, and there they actually recommend the evidence-based parent training and behavioral management. So PTBM is what you'll see when you go into their guidelines. And essentially, it's parent training and behavioral management. And then you think about that's also behavioral interventions for the child and such. So essentially starting with the non-pharm. And then they do talk about that if that fails after so many months, then you can consider drug treatment, and typically methylphenidate at a lower dose is our first line agent for our preschool children. The next age group is the 6 to 12 year of age patient. So it's really 6 to up to 12. And then that age, they do discuss, again, the parent training and behavioral management, but also like the behavioral therapy, the classroom interventions for that child. It's not just, the parent training. The child is old enough to do all of the behavioral training for themselves, as well as an FDA approved medication. And so using both is ideal. We can't get them to do the behavioral therapy, at least definitely starting a pharmacotherapy option is recommended. And then the next age group is at 12 and above, so the adolescents from that perspective. And we actually don't have like ADHD adult guidelines. Everyone just really uses that adolescent and above data from the AAP typically. And again, my practice is limited to pediatrics from that perspective. And then for those patients 12 to 18, using an FDA-approved medication is recommended with the patient. And then hopefully they would also agree to do some type of training intervention to help their behavior or organizational skills or whatever it may be. And so you asked, what is our first-line agent? So the first-line agents for pharmacotherapy are our stimulant medications. And we have our 2 stimulants in this one class, and one's the methylphenidates and one's the amphetamine products. When you get into what should we use, the guidelines don't recommend one or the other. They recommend using a stimulant. And actually, you'll see most of the guidelines, even if you go to the European, the Canadian, they just say stimulant. They don't recommend one over the other. When you look at it, you'll see some people will recommend methylphenidate in children, adolescents, and adults to start with an amphetamine product. Children tend to tolerate our methylphenidate products better than the amphetamines, but yet they're both efficacious. They both have an effect size of 1.0. And so we have to just think about what's best for your patient and then start with one. And if that one doesn't improve their symptoms, or you get to max doses, or you have side effects, then switch to the other. And that's the same way if you start with an amphetamine, it's not working for various reasons, and you've tried different ones, you've gone up on dose, maybe you switch to a methylphenidate product. So both are equal from recommendation standpoint. It's finding the best product to me for your patient and starting with that product.
Yeah, I think the other thing that obviously it gets sticky and confusing is just like you're saying, there's so many various dosage forms. And like anecdotally, I feel like I've never had good success when a provider just goes to an XR version off the bat. I feel like I like to do the IR, get their dose straight, and then do the XR. Can you talk about just like the different dosage forms, why you prefer some over the other, and some of the caveats? I know I don't think anyone could possibly memorize what you take with food, what you don't take with food. Alcohol throws a whole nother wrench into it that I feel like our adolescents need to know about. So again, any pearls that you have surrounding the dosage forms, just because it's almost overwhelming the amount of options that you have.
There definitely are a lot of options, and new products continue to be coming to the market. I think there are a few ways to do it. So you mentioned starting with an immediate release, which has a duration of about 4 hours, and finding an appropriate dose. So then that way you would probably be on 2 doses a day to find the right dose to titrate and find the right duration. Otherwise, and then it sounds like you'd switch to an XR formulation or a long-acting formulation of stimulants, whereas other options are to start right out with a long-acting product. Your long-acting products tend to allow that adherence to improve because we just give it once a day, and we then can find, the child hopefully does take it, or adolescent, and we have that efficacy. The dosing titration is definitely an issue because you never know where that patient's going to end up on the pendulum of doses per se. And so when we look at, we pretty much only have short-acting and long-acting products on the market today. If you actually go look at that ADHD article review in JPPT, we do have dosing. We have charts that give you all the different drugs, the pharmacokinetic profiles, the dosage forms and such. And I think that is something that, make your own if you need to. And I've been making this chart for years, and I have my students come together and they create the chart as a whole class, and then we talk about it so they can learn the differences. So I think you have to find what you like to use. So let's go back though. What do you first start off with? Well, when you have a patient and you have diagnosed ADHD based on our DSM-5 criteria, and you're going to do behavioral and you're going to do drug therapy, finding that right drug. So first of all, you have to decide, are you going to start with a methylphenidate or an amphetamine product? And then honestly, the next thing I'm going to do is look at their insurance to see what is covered, because these newer products are several $100s a month. And we have many generic products on the market that you may be able to get for a lower copay or a lower cash price. So I'm going to look to see what are my options, but I am going to tie that into when my patient's symptoms are the worst. So we have some patients who have ADHD, and it is just like morning is not fun for that parent, for that child, for that adolescent. They can't get out of bed. They go through 5 snooze buttons. And do I really have to get dressed today to go to school? Yes, right? Like it's getting them to eat, getting them to get their backpack, getting them in the car, right? Everything is a challenge, to where others can somewhat, maybe that's not as bad per se or not as challenging, but going through the day and, oh my gosh, they come to 2 p.m. and they can't concentrate and they can't focus, and they need more afternoon aspects. Or when they get home, you can't get them to pay attention, to sit down, to do their homework, to be focused. So I'm going to look and determine within that 24-hour period, when are my patient's symptoms the worst? And they, as Justin, you were asking, what's the priority? Is it to get morning control, or is it to get afternoon control, or lunch control, or, not early evening, but I'd say late afternoon control? I'm going to match that up with the pharmacokinetics of the medication. because we have in the long-acting products some drugs, if you take a dose and it's a 50% first release, second release drug formulation, half of that drug, so if I take a 10 milligram dose, 5 milligrams is the immediate release and 5 milligrams is 4 hours later. But maybe it's only an 8-hour duration drug and you need more of a 10-hour duration. So I'm going to look at all those characteristics. Do I need more morning? Because there's some drugs that don't have a lot of morning immediate release, but have later in the afternoon. And then some that have a lot in the morning. And then we have drugs that don't have any of that kinetics. And it's just a standard drug, traditional drug that you think of, you take, it starts and it wears off, right? And so I'm going to try to match up my patient's symptoms and when they need the most efficacy with the best drug and the best pharmacokinetic profile and dosage form that they can take. If I need a liquid, then I'm immediately dropping down to just my liquid formulations. Or maybe I can do a chew tab. Or maybe I can do a capsule that I can open and sprinkle, but we have some tablets you can't open. So maybe that's a drug I can't use in that patient. So there are many factors in picking the first drug that I'm going to consider, but it's that when does the patient need the efficacy? How's the drug designed? But really, what can they afford and what can they get? That's going to help me limit, Jenna, from my 20 drugs to choose from down to maybe 5, and then I pick the optimal one for the patient.
Yeah, thank you. That's super helpful.
Yeah, I love your approach, Lea, because if I'm being honest, sometimes I see providers getting in a rut of this is just what I start first for all my kids because it's the most flexible. Like there's one that I can open and sprinkle and it's going to work for 80% of my patients. But the reality is, I think if we look at the trust the family has in us as we're recommending, when we ask them all these questions, what time do you get up? When do you have to be at school? When are the symptoms worse? Are you having issues with homework at night? And you really map all this out. You're figuring out what dosage form they need. They trust you, and you have this trust relationship that allows you to really invest in helping them to optimize outcomes. So I love the approach that you've just noted there. You know, I also find it interesting that when we look at the pharmaceutical preparations we have for stimulants, I don't know of any other disease state, even in adults, that we've had that much creativity in dosage forms. I mean, it's just crazy. There's even one now that can be taken at night before bed. It's delayed release, and then it's extended release once it starts releasing in the morning. It's just crazy how far we've come. So, we've got to customize this. It's all about that individual patient and family. I'd also love to ask if you could tell us just a little bit about some of the non-stimulants that are available. Sometimes kids may have side effects to stimulants that they're not tolerated, or we've just got to move on to something else. So maybe tell us a little bit about where you're seeing non-stimulants fit and what agents are available.
Sure, Justin. So I think there are some definite times you would maybe want to use a non-stimulant first as a pharmacotherapy option, just like you were saying. Well, first, it could be that they failed stimulants. They just can't tolerate them. They have side effects, whatever it may be. But also patients who have history of drug abuse or drug abuse in the family. These drugs can be sold on the street, you know, and so I've had it where, unfortunately, little Johnny's not getting his medicine because, you know, sibling, aunt, uncle, whoever's selling it instead. So I think there's certain reasons going to a non-stimulant first line can be appropriate for that patient. We currently have 2 classes that are used as non-stimulants, norepinephrine reuptake inhibitors, and that includes atomoxetine and viloxazine. And those 2 agents, atomoxetine's been around since I think about 2000, early 2000s. Strateris, their brand name. Quellbree's the newer one that just came out a couple of years ago for it. And these are products, what's nice, they're capsules. One you can open, one you can't open. So you have to figure out what would maybe be best. And here you're hitting a little different. It's a norepinephrine reuptake inhibitor. So we're not dealing with this, you know, serotonin or dopamine. We're going to a different neurotransmitter aspect. Now with that drug class, you do have some concerns. We've got definitely hepatotoxicity concern. All of the ADHD, you know, but this one also has or not all the ADHD, but the suicidal ideation aspect you want to think about in children and adolescents. And, we still have other CNS effects that can occur. But these drugs, what's also important to remember is you need to take them absolutely every single day. And it takes about 2 to 3 weeks to see an effect, whereas stimulants, you can see starting efficacy within a couple days of taking a stimulant. Yeah. And there used to be a whole thing about, drug holidays and not taking it. That's a whole nother topic, right? But for norepi reuptake inhibitors, you've got to take every day, no matter what, to keep that efficacy going. The alpha-2 agonists, guanfacine, clonidine, these are popular again. Newer products came out as an extended release years ago, and we just had another long-acting product, extended release for clonidine just get approved in the last couple months, weeks. And so these two products, you have to think about, they're the alpha-2 agonists. So they are helpful. Now, when you look at non-stimulants versus stimulants, stimulants have an effect size of 1.0, non-stimulants are 0.7. So we know their efficacy is not as strong as our stimulants. However, they can still be effective. And they also may be good as an adjunct. So maybe we don't need to go to a higher stimulant dose because we're getting more adverse effects, but I can have an adjunct and put this in as a second drug, unfortunately, to go to second drugs, but have a second drug and I can still treat my ADHD without having more adverse effects and yet getting better efficacy. The alpha agonist, you still think we use different dosing than if you were using an alpha agonist for hypertension, but we still need to monitor, the cardiac effects. We have to watch for that rebound effect as well. What's also important is when we're changing these drugs, you don't ever, from stimulants to non-stimulants and back and forth, they're not all equal on a milligram to milligram basis even. And for example, even if you're going from immediate release guanfacine to extended release guanfacine, you start over at 1 milligram. You don't have a milligram to milligram equivalent. So you have to really understand. And Jen, I know you asked, how do you remember all this? You don't. That's why we have to use our drug information resources. That's why some, good charts or whatever you can make to help you remember these things. Always go back and look up things. We just all have to do that. I always tell my students, if you have a pharmacist saying they know everything, I don't want them as my pharmacist because we can't know everything, but you need to know where to look to go help find that information. Yeah. So Justin, hopefully that helped a little bit about the non-stimulant therapy.
Yeah, I would love to ask just a question that I've seen. I think we are so focused on, you have to use stimulants, but I think it gets so gray when you start seeing side effects that I've, as our patient population that has ADHD has expanded, I've seen some wild stuff. So we're talking about side effects. Obviously, first off, can you elaborate on the side effects? And then I have a couple targeted questions on, when do you pull the trigger to say, okay, stop? Because I'll tell you how there's this nasty prescribing cascade that I've seen from the side effects of the drug that have gives you all this polypharmacy. But first we'll just ask, what are the side effects of the stimulants you're referring to? And then I have a couple probing questions after that.
Sure. So general, what is nice is your side effects from our methylphenidate and our amphetamines are very similar, right? Because it's mechanism of action is that same, but you definitely have a decreased appetite. And so a lot of our young kids, they just may not be as hungry anymore. And so they're really what I do. I really look at the patient. We monitor the weight. It's not just subjective. We're going to look at objective data. And if we definitely have weight loss and our parents are we're now administering it right after they eat, we're giving them fatty meals, then I'm going to change my drug because I am not going to put my patient at a weight loss issue for any reason from that perspective. Sleep disturbances can happen. Why? Because this is a stimulant, right? So then you can't get them to sleep. They aren't going down. And then some people, this is when they will use even an alpha agonist to get that sedation ADR and help the child go to sleep and help the ADHD. But if you're having sleep disturbances, I always go back and look, when did you administer the drug? And are we administering it at 9 in the morning versus 7 or 8 in the morning? Let's make sure we're optimizing our timing of the drug. And then you do have to worry about as you mentioned, Justin, we do have our one product that you administer at night. And the studies for that administered it between 6:30 and 9:30. 8 o'clock was on average the recommendation time. Well, at 8, are you in bed at 8? Is your child already asleep at 8? There are nights I could be asleep at 8. So how does that play a role in their, family from that perspective? So really making sure also, the other behavioral measures just for general sleep hygiene is good. You definitely can have like an increased aspect of like the behavioral aspects in our younger children and sometimes the older. I watch more for in that preschool is, did we have more anxiety, more like emotional disturbances come about? Are we really, are we causing more harm because we've had more behavioral changes from this drug than not using this drug at all? And so I'd look at that, and if I can decrease my dose, so, you were asking, what do you do? So many times if I'm having an ADR, I first try to see, can we decrease our dose and lose the adverse drug reaction, but yet maintain efficacy? And if we can't, then I have to think about considering to switch my drug, either to another product or to a whole nother drug, an actual drug difference from class. Yeah. I mean, it's kind of hard to say, like I go from methylphenidate to amphetamine. They're still in the same class, but I would still switch from one to the other or go back and forth. Or then go to a non-stimulant from that perspective. So all of our drugs, the stimulants, still have the concerns of like, we do want to monitor height, blood pressure, heart rate, just because you can have increases in our, catecholamine aspects. So we do monitor for those. But I personally, in clinical practice, haven't had to see a change in drug due to those ADRs. It's typically the increased or the decreased appetite, sleep issues, or behavioral aspects that we're changing.
So it's interesting because how we're scattered all over the U.S. and then you kind of get into pockets where you can see prescribing trends, right? And so in Minnesota specifically, we have patients that are on amphetamines and then they have a decreased appetite and then they add cyproheptadine to stimulate their appetite. And then like nobody's addressed that they're not growing. So then in addition to the cyproheptadine, I've had kids on growth hormone. And so I again, there's this, and it's common. And so I'm like, what am I missing here? Why are we still on a stimulant? Why haven't they come off? And I think this is where I'm a student to you is I'm in the school of like, oh my God, they're on a growth hormone, they're on cyproheptadine, like take them off the stimulant, not switch them to another stimulant. So when you said switch them over like to another stimulant, that piqued my interest because that's not something that I do. I'm quick to be like, let's do a non-stimulant. So I guess it's more of like a question. Do you see this in practice? What's your clinical opinion of this? In my eyes, I'm like, oh my God, get them off. I like freak out. I'm like, and then they're on, God forbid it's an antipsychotic they need. Now we're having all these anticholinergic effects from the cyproheptadine. I mean, these are real things that we see in practice that like, I just want to take them off real quick, but I would love your input on that.
Yeah, I guess that's where we say in the South, bless your heart. Oh my gosh, like we've got to take off these drugs. Like if you, if anything, my gosh, we're pharmacists. You don't want to keep treating side effects with other drugs. So fortunately, we have not gone to that practice of giving more drugs. So what we would do, though, is, the data shows if they're not tolerating methylphenidate I'm just going to say methylphenidate, for example, and maybe they are having that decreased appetite and you've tried to optimize the kinetics of the drug and the patient, switch them to an amphetamine and just see if it's better. But I mean, remember what's nice about the stimulants we talked about, you can start it and bring them back in 2 weeks and see if it's improved. Like, and if not, like we don't have to wait 3 to 4 months to see if something's working or something's not working. And so you can switch them. Now, if you have a family member who's like, I am not going to take any more stimulants, then fine, absolutely go to a non-stimulant because that's going to be better than no therapy at all, right? But no, I definitely do not agree with the aspect of adding more drugs to treat the side effects. And that is where, if you look at any general ADHD drug resource, or review chapter or review or a chapter, it gives you ways to titrate and to do different things to alleviate and manage these ADRs. And nowhere do we say give other drugs. So, I mean, I'm right with you. I can't believe even growth hormone would get approved for that, like, from the insurance company from that perspective.
I've seen it so frequently, I guess, again, specifically within this geographical area. And I can't tell you the amount of kids we've seen that are on stimulants that have cyproheptadine, among other drugs, added for, or even like, a bunch of sleep medications added, like, trazodone or mirtazapine. And it's like, whoa. Did we ever, just like you're saying, move the doses to an earlier time of the day or decrease the dose or anything? So it's an important thing I wanted the listeners to be cognizant of, that when they're looking, obviously, at these children that are on the drugs, like, please don't use another med to treat the side effects, because it's happening a lot. All over. And so thank you for commenting on that.
Jenna, one of the things I'll add, and Leah's made this point really plainly, the vast majority of side effects of stimulants are dose-related.
That's all for today's episode. Thanks for listening, and remember to subscribe on Apple Podcasts and leave us a review.